मेरा एक जूनियर था चंदन चौधरी, जानते थे? MCH करके अभी दिल्ली में है।
सर हम लोग लाइव होने वाले हैं। प्लीज सब लोग म्यूट हो जाएंगे, मैं बताऊंगा सर।
और लोगों को कॉल कीजिए। शमसुल जी
सर हाँ बस प्लीज सब लोग सर म्यूट हो जाएंगे सर। मैं लाइव कर हो चुके हैं सर लोग। और I'll just tell you sir. Very good evening from Ortho TV. Welcome to Ortho TV online education webinars. Today we have Bihar Orthopedic Association's webinar on World Osteoporosis Day. Now I request our secretary to start the webinar. Please, sir. Manoj sir, please start, sir.
Thank you. Thank you, Shamsul ji. Welcome in this webinar focused on osteoporosis. Today is Osteoporosis Day. This is observed worldwide, and that's why this is called World Osteoporosis Day. With this, a flash comes into our mind why at all osteoporosis is so important, that a full day, rather a full year is dedicated and is observed worldwide. In fact, this is a household problem. This is a very common problem and should not have been so important, is not it? But I am awfully sorry to say that this is not true. Osteoporosis causes morbidity more than any other conditions which we usually know, that is hypertension and diabetes. Actually, this is second most common disease than osteoarthritis. If you search for data, you will find that 1 among 5 men are suffering from osteoporosis and osteoporotic fractures. And if you go for female data, it is still worse. 1 in 3 female suffers from osteoporotic fractures. So it is very important, and we must focus our attention. We must address this disease. Particularly today, we have to discuss, and that's why this webinar is. Now, I shall request Dr. Shamsul Huda, who is moderator also, to conduct this meeting.
Thank you, sir. Now I request our secretary, BOA Madhusan sir, to say what, sir.
Respected President sir, President-elect sir, all the seniors and all the speakers and all the members of the BOA and all the orthopedic surgeons who are here. World Osteoporosis Day, also known as WOD. It is celebrated all over the world on 20th October every year. Its aim to make osteoporosis, fracture prevention and global health priority. It's prevention, diagnosis and cure to whatever extent possible. The awareness program emphasizes on the direct link between the osteoporosis, the silent underlying disease and broken bones, which has serious impact on the one's life. Today, sir, 1 female out of 3 female, 1 male out of 5 male above the age of 50 years are affected by the osteoporosis, making it a global burden. So, this webinar is going on the World Osteoporosis Day today, and I hope this program will grant success. Our speakers are the very talented, like the Arvind Gupta and others, like the all the speakers and presidents are all are here. Rohit Mahipal is also here. So I request all of you to conduct the program. Thank you.
Thank you, sir. The first topic for today is by Dr. Manoj Chaudhary, sir. Osteoporosis, the silent killer. So I request Manoj Chaudhary, sir, to share his presentation first.
Seriously. Thank you. Stop. Yeah. Thank you. Hello, am I audible? Hello?
Yes,
No.
sir. Yes, sir.
Yes,
Please
sir.
start, sir. Yes,
Start
sir.
करूं?
Yes, sir.
Bilkul, sir.
So, my topic
You
is,
can start, sir. Your slide is visible, sir. Please, sir.
So my topic is osteoporosis, the silent epidemic. In past, we have faced many epidemics. These are some pictures of those epidemics. And today we are facing the challenge of COVID-19, and we are scared of it. Why? Why so? Because we find it detrimental to our health, life, and earnings. These epidemics gradually lose their fangs, and we forget them. One condition which from population silently steals health, makes life miserable, loss of earnings is innocent-looking osteoporosis. The clinical consequences of osteoporosis is fatal, and it has a similar effect, just like other epidemics, they on health, life, and earnings. We are facing this. This is the story of every family, village, town, state, or country. Nobody is spared. So we call the osteoporosis a silent epidemic. The National Osteoporosis Society of the United Kingdom took an initiative to bring awareness in society about the detrimental effects of osteoporosis. And they conceived the idea of Osteoporosis Day. And this Osteoporosis Day was launched on October 20th, 1996. Today is 20th October 2020, and we are observing World Osteoporosis Day. This World Osteoporosis Day is supported by European Council since 1997. World Osteoporosis Day marks the year-long campaign dedicated for prevention, diagnosis, and treatment of osteoporosis in the population at large. What are the aims of World Osteoporosis Day? Actually, there must be some aims. What we are going to do? So, we cannot leave everything on doctors only, health professionals only. So, the aim is to make osteoporosis and fracture prevention a global priority and involve health professionals and as also the policymakers and public at large. If awareness will be there, the treatment, the management can be done efficiently. Professor Cyrus Cooper, who is the president of International Osteoporosis Foundation, he is of the view that World Osteoporosis Day is a key date in the bone field. It is an occasion when people around the globe unite to put the spotlight on immense global burden caused by osteoporosis. This year, the campaign was launched in Russia on September 1st, 2020, with traditional children drawing competition under the slogan, "My parents and I are strong and healthy family. Osteoporosis. The definition is know that it is a generic term referring to a state of decreased mass per unit volume of bone. The structure of bone, we all know that it is a specialized connective tissue providing rigid skeleton and gives all important shape to body. It is not merely a pile up of calcium, rather simulates pillars of concrete, which is a mixture of cement, stone chips, and water. Similarly, bone has protein framework with calcium and minerals impregnated in it. The bone is called osteons. Osteons are three types. Osteoblasts that form the bone, osteoclasts that remove the bone, and osteocytes, the resting cells. And it has cortex and medulla. We all know, we are orthopedic surgeons. And we know normal bone, osteopenia, and osteoporosis. The decreased density in osteoporosis is due to deficiency of protein matrix, which calcium is down, and rate of absorption is more than rate of bone formation. Osteoclastic activity is more than osteoclastic activity. The DEXA criteria is important. The DEXA criteria for osteoporosis as determined by WHO are DMD of spine and hip of 2 to 5 standard deviation below mean healthy women, that is T-score of minus 2.5 or below, and osteopenia between 1 to 2.5 SD or more mean. So what we have to do to prevent fractures or detrimental effects of osteoporosis? We must screen the population at large. So how many person, what is group, or what are the criteria for screening for osteoporosis? This cannot be blanket. So the criteria is all women above 65 years of age and all men above 70 years of age should be screened. But in few cases, in few selected cases, just like postmenopausal men and men between 50 to 70 years with increased risk of factors or comorbidities should also be screened for osteoporosis. Why women are more susceptible to osteoporosis? And this is because of 6 Ds: their diet, they do not have ample of diet or healthy diet, or difficulties. They have difficulties in going outside. They remain indoors. They are deprived of sunlight, and therefore they have deficiency of vitamin D. Now coming to drugs, as our tradition is, women do not go outside, and if they fell ill or have some minor ailments also, they go to quacks. The quacks are everywhere, and these quacks, for rapid relief, prescribe some medicines, steroids, and these steroids have very bad effect, and they cause osteoporosis in women. Day-to-day activities also prevent them. They are engaged from the morning to evening, at night also they are engaged in their day-to-day activities, and they do not have times to spare for themselves, for their health. They cannot do yoga, they cannot go outside for morning walks, and therefore they are become more susceptible, they fall prey of osteoporosis. Deficiency of hormone estrogen, we know that this is physiological, and after menopause, this is bound to happen, and so the women are more prone to osteoporosis because of this estrogen deficiency. Dependence and culture and traditions also add to their miseries. For example, they have the habits of offering prayers first and then have their first meals. And by the time the sun goes high in the sky, it is almost noon. All the fastings that is meant for our women only, not for men. So all these add to their condition and they become osteoporotic very rapidly. That is why women are 1 in 3 women have osteoporotic fractures compared to 1 in 5 men. So what is this year's campaign includes? They include the human causes of fracture, encourage the public to check their personal risks by osteoporosis, improve understanding of the link between osteoporosis and broken bones, raise awareness of the osteoporosis, urge healthcare authorities worldwide to implement post-fracture and secondary fracture prevention. This has been found. This has been found that once a fracture occurs, the rate of refracture is almost 60% or more. Reveal the socio-economic burden of the fracture. So what is the take-home message? Take-home message is, once we are ignorant, we do not know what is going to happen, and we are very cheerful. So normalcy leads to ignorance, and ignorance is blissful. Normal people with point of view of a common person will tend to ignore a lot of small clinical features, while a doctor would not. An orthopedician, salute to that. So it's important as a doctor not to ignore anything, looking for the signs and symptoms of osteoporosis in our mind, in our kids and kins, and we are sure to bring a change in society. Thank you. Thank you for listening. Thank you all.
Thank you, sir. Please, sir, stop your screen share, sir.
Dr. Samsul?
Yes, sir. Yeah.
Next speaker, announce the name. Next speaker.
Yeah. Thank you, sir. Next topic we have from Dr. Rohit Mahapal from Siliguri. His topic is clinical feature and investigations in osteoporosis. Dr. Rohit, your slide is ready.
Yes.
Here.
Thank you, sirs, for allowing me to speak in front of such an august gathering on such an important topic. And thank you, Manoj, sir, for a wonderful presentation.
Thank you.
Thank you, sir. I'll share the screen now, Dr. Samsul, sir.
Please,
Yeah.
Please do.
Yeah. Okay. So, a very good evening. Today, the topic that I'm going to talk about is osteoporosis, its clinical presentations and diagnosis. So, So the aim of the presentation is defining osteoporosis, which Dr. Manoj sir has already done, but I would just be brushing up on it. Talking about the clinical presentation of osteoporosis and investigations that are pertaining to osteoporosis. So by definition, osteoporosis is a systemic skeletal disease that is characterized by a low bone density mass, a microarchitectural deterioration of bone tissue that leads to enhanced bone fragility and increase to the risk of fractures. This is a bit confusing definition, but WHO classified it very simply in terms of the bone mass density levels, that is the T-scores, saying that a value of more than -1 T-score is normal, between -1 to -2.5 is osteopenia, that is the low bone mass, and less than -2.5 is osteoporosis. And in the presence of a fragility fracture, it classified as severe osteoporosis. So osteoporosis, there are innumerous causes. The most important and the most prevalent is the postmenopausal osteoporosis. The prevalence of osteoporosis as well as its related fractures are higher in postmenopausal women than in older men, since estrogen plays a key role in maintaining bone health. Starting at an early age of 30, women tend to lose small amount of bone every year as a natural part of aging process. At around menopause, with the decreasing estrogen level, there is an increase in the rate of bone loss for about 8 to 10 years, and which tends to return back after that to the premenopausal rates. A lifetime risk of fracture for a 60-year-old woman is close to 44% as compared to a male of the same age, which is around 25%, which is almost double. Secondary osteoporosis, there are numerous causes for secondary osteoporosis, and probably not under the scope of this webinar, but I would like to mention two of the secondary osteoporosis. First is the glucocorticoid-induced osteoporosis. We as orthopedic surgeons, many physicians, other doctors, as well as quacks, we tend to prescribe glucocorticoids. Sometimes patients tend to take it for a very long time without any advice, or their advice accordingly for different ailments, and these leads to osteoporosis. How it works is there is a blockage of the vitamin D action, which ultimately leads to a decrease in calcium absorption. There is increased bone resorption and depletion of osteoblast cell population. This ultimately will lead to osteoporosis, and this is a very important thing to consider as far as orthopedic surgeons are concerned. Another thing, in case of CKD, though CKD will lead to decreased vitamin D levels as well as calcium accumulation, but there is an increased risk of fall due to muscle weakness, and patients tend to fall a lot. That leads to fractures in such patients. Another important thing is excessive consumption of soft drinks, smoking, excessive alcohol consumption, and recently vaping has been considered to be a cause of osteoporosis because of its nicotine content. The single most important factor for osteoporosis development is lack of exercise. When I talk about lack of exercise, I do not talk about lack of exercise at the age of 50 or 70, though it is important. But I talk about lack of exercise early on in life, that is before 30 years of age. What happens is at the age of around 25 to 30 years, a person will gain the peak bone mass, that is the maximum bone density he'll have for his own lifetime. So before that, if a person has done his share of exercises, that leads to an increase in peak bone mass and ultimately a lower chance of osteoporosis. But we Indians are a bit towards the sedentary lifestyle, and that ultimately leads to an increased incidence of osteoporosis. So there are few types of clinical presentations that osteoporotic patients present to an orthopedic surgeon. First, we have patients, which is very common actually. First, we have patients with these fractures, especially in the hip, the wrist, and the spine, after a trivial fall, and in case of vertebral spine, even without a fall. We have patients with back pain, especially in the low back, at an advancing age, obviously. We have patients who come with such kind of report after getting it done over from a corporate hospital as part of the package, and even in non-corporates too. And they have come to us for understanding the report and probably, for the treatment of this particular report. And then we have patients who come at the age of approximately 80 or 90 to our OPDs with their children and grandchildren saying that my grandmother has lost her height over the years. And lastly, but not unimportantly, we have Dr. Google who advises patient about the condition of their ailments based on their search history, and patients come to us for the treatment. So clinical presentation is an important aspect of diagnosing osteoporosis and related fractures. And we have already talked about various kind of X-ray presentations that the patients present to our OPD. The purpose of biochemical tests in case of osteoporosis is to rule out secondary osteoporosis and not to diagnose osteoporosis. The range of the test can be varied, and it depends on the severity of the disease, the age of presentation, as well as the presence and absence of fractures. And the aim of these tests is to exclude causes of osteoporosis and its contributing fractures, assess the risk of subsequent fractures, and select the most appropriate form of treatment for these patients. An important tool for diagnosing osteoporosis is a dual energy X-ray absorptiometer, which basically works in the concept of two X-ray beams having different energy levels striking at the bone of the patient. And when the soft tissue absorption is subtracted out digitally with the help of the software, the bone mineral density is provided to us. The importance of BMD is for screening. The importance for, at least for us orthopedic surgeons, is to understand when to screen for osteoporosis using the DEXA scan. So after the age of 65 years for female and 70 years for male, it has to be routinely done. That is the recommendation. Below that age, the patient should have some or other risk factors to actually diagnose him, to actually screen him for osteoporosis. He or she should have a fragility fracture after the age of 40 years. Parenteral hip fractures should be present. That denotes genetics, the involvement of genetics. Medications with high risk of bone loss, such as glucocorticoids. Smoking, alcohol, disorders associated with osteoporosis, such as rheumatoid arthritis and ankylosing spondylitis. Low weight and recent major weight loss. These all should indicate a possibility of osteoporosis, and the patient should be screened with DEXA scan. So this is a common report that we usually observe with a DEXA scan. So what we have here is but the important thing is to understand the significance of a T-score or a Z-score. So what the T-score is basically is a comparison of a person's bone density with that of a healthy 30-year-old person of the same sex. Whereas Z-score, there is a comparison of the person's bone density with that of an average person of the same age and sex. T-scores are standard. There is no doubt about that, because when we consider Z-score, we compare it with the same age. So let's say there is a patient of 80 years of age having a Z-score of 0, but a T-score of -2. So a Z-score of 0, that is, as compared to other people of her or his age, he has a comparable Z-score, but his actual T-score is -2. That means he has osteoporosis. So Z-score ultimately does not directly provide in diagnosing osteoporosis, but then it helps in differentiating the causes of. It helps in indicating whether the person can have other secondary causes too. An important tool is the fracture risk assessment tool. Several clinical factors are associated with fracture risk that cannot be actually accounted by bone mineral density alone. So the aim of FRAX is to provide an assessment tool for the prediction of the fracture in men and women using clinical risk factors with or without bone mineral density, especially the hip. So it calculates a 10-year probability of a major osteoporotic fracture in various bones. The 10-year fracture probability calculated by FRAX, it helps in identifying a subset of osteopenic patients, that is low bone mass patients and not osteoporotic patients. A set of osteopenic patients who are having a higher fracture risk and who are most likely going to benefit from an osteoporotic treatment. So this is a standard FRAX tool scoring system. So we have different, apart from BMD, we have different risk factors that are usually considered here. Each and every one of them, that includes the age of the patient, the sex of the patient, the weight of the patient, family history of fragility fractures, a family history of parenteral hip fractures, current smokers or alcohol abuse, previous injury, use of glucocorticoids and associated rheumatoid arthritis is important. What I mean by this is a person having a T-score of -2.5. The probability of hip fractures at say at the age of 80 years is approximately 5 times as high as compared to that at the age of 50 years. And other risk factors have been known to contribute independently to fracture risk. Moreover, an important point to consider is treatment of osteoporosis should be considered for patient having a low bone mass or osteopenia along with the 10-year risk of hip fractures of more than 3% and 10-year risk of major osteoporotic fractures at more than 20% as assessed by FRAX. We have another set of investigations, that is the bone markers. Most bone marker components apart from the bone are also present in other tissues, and they are influenced by non-skeletal processes too. Changes in the bone marker are not disease specific, but they denote bone metabolism involvement, and helps to identify the underlying cause. So we have two sets of bone markers, that is the bone formation markers and bone resorption markers. We have innumerous numbers of markers, but I'm here talking about two of each, which are very commonly used, especially in India. We have the bone-specific alkaline phosphatase. We have the amino-terminal propeptide of type 1 collagen as bone formation markers. And in bone resorption markers, we have the C-telepeptide of collagen crosslinks and N-telepeptide of collagen crosslinks. In India, we have the CTX and NTX, we have the urinary assay. So the problem with the bone marker is that it has a very high cost. Factors such as time of day of collection, the diet of the patient, whether the patient is empty stomach or not, the activity level of the patient, seasonal variation, and drugs, they affect the marker assay. And there has been known to be, the assay has been known to have a variability of approximately 10% for serum assays and 30% for urinary assays. Therefore, it is not a good tool to consider for diagnosis of osteoporosis, but it is very useful for monitoring the effectiveness of therapy, predicting the response to therapy, and predicting fracture risk. To summarize, it is a silent killer. The most common presentation is fracture following a trivial trauma. Lack of exercise plays a major role in development of osteoporosis. Blood tests are usually required not to diagnose but find out secondary causes, and DEXA scan along with FRAX scoring is an important tool for diagnosing and planning of management. Thank you.
Thank you, Dr. Rohit, for a wonderful talk. I request you to share your screen, please.
Yes, sir.
Thank you, sir.
Awesome.
Now, next we have a talk from Dr. Arvind Gupta. Your slide is ready, Dr. Gupta. Please unmute yourself. In the meantime, if any panelist has any question, Saraf sir, would you like to say anything?
Unmute, sir. Unmute.
Sir, your volume is low, sir.
No.
Sir, you are mute, sir. Saraf sir, you are mute.
Yes.
Yeah. Now I'm audible. There are so many things to be added in osteoporosis. Like, I have to give one information, how you analyze the BMD report. Because in BMD report, we find 2 or 3 pages of the report. And in first page, in most of the reports, the diagnosis is osteopenia. So we are a bit confused. When you see the second page, you find some clues. I have some clues. Like, you see the lowest score, T score, in report, in any region, like neck of femur, trochanteric region, or radius, or any bone, or spine, and you multiply with age. Suppose if T score is 3 and you multiply with, and the age of the patient is 40, you multiply with 3. It is 120. So if the finding is between 100 to 200, there is a low risk of the fracture. Suppose the T score is 3 and age of the patient is 70. You multiply with this. So your finding is approximately 110. So risk is moderate. And if the finding is more than 300, the patient has got high risk. So this is simple formula. You multiply the lowest T score with the age of the patient and find what is that. If it is between 100 to 200, the low risk, the patient is of low risk case. If it is more than 200, moderate risk. If more than 300, patient is of high risk of the fracture. Just this will, I will like, this is one information I have to give you. Otherwise, everything was good.
Thank you, sir. It was a wonderful information. Even I didn't know that. Thank you, sir.
Very good information.
Yes, sir.
And this will benefit everybody who will be listening us. Thank you, Dr. Saraf.
Thank you, sir. Now I request Dr. Gupta to start a slide.
Dr. Arvind Gupta ji.
Thank you, BOA and Manoj sir for giving me this opportunity. My talk is little bit bi-directional. I will take opinion from all of you. So recently we had this World Arthritis Day also, and today we have World Osteoporosis Day. So I am clubbing both of these two in my case presentation. I'll start with this postmenopausal lady from village, and she is walking like this. For 6 years, she has pain in bilateral knee, and she used to take some medicine from Quick. As Dr. Rohit has said, the steroid is having very bad effect on the bone quality. That leads to osteoporosis by blocking the effect of vitamin D and other part also at the cellular metabolism. So she is taking almost a steroid for 5-6 years, and now she is walking like this. The leg, you can see the condition of the leg, and the patient is having difficulty in walking even with the support. So definitely all the investigation as described by Dr. Rohit, so that was investigated, and her vitamin D was very low. It was almost around in the range of 8, and the rest parameter was normal. Hemoglobin was little bit on lower side, and the rest parameter was normal. And thus he was walking like this. And so further X-ray was done. So this was the X-ray. This is the AP view, both side, and this is the lateral view. Sorry for the lateral view because of little bit bad photography, but you can very clearly see everything in the AP view also. So Dr. Rohit.
Yes,
Hello.
sir. Yes, sir.
So can you take this?
Yes, the X-ray shows severe arthritis of the knee joint as well as fracture at the proximal tibia.
Yeah. So what do you think? Which type of this fracture is?
Sir, I want to ask: was the patient on bisphosphonate or
no bisphosphonate?
No bisphosphonates.
No any other drug other than some type of puria that she used to take from a Quick.
Looks like an osteoporotic fracture, sir. But
yeah, definitely. This is a stress fracture. You said also that also you can say the opposite side there is also the stress fracture is developing there. So this stress fracture is one thing. This is because of the biomechanical consequences. When there is severe varus is there, all the load comes on the medial side of the proximal tibia, and from there bone start cracking. When your bone is osteoporous, when your vitamin is very low, and you are taking steroid and something other type of thing. So this patient is having both the severe osteoarthritis also, and this stress fracture because of osteoporosis part. You can see the proximal part of the tibia is very pure. So what should be the next treatment, Dr. Gyan Ranjan?
Firstly, I would like to correct the biochemical levels. Like vitamin D is very low. Vitamin D should be given, and this fracture should be stabilized. Immediately, it should be stabilized, giving a slab or anything. You should start with vitamin D. Better a shot of erythritol. That might help, and again we can repeat it for a while. And in the meantime, we can go for quadricep and hamstring exercises. Whereas in right knee, we can use hinged knee brace, which can give her a better movement.
So you don't think the mechanical malalignment is a problem here?
Yes, that is there.
Exactly.
So nothing is going to help in this case because there is severe varus deformity. Correction of the deformity is foremost, and that's why she needs some corrective measures, and then only this fracture will unite. Otherwise, it is not going to unite.
So
this is my opinion.
Yeah. So by principle, Gyan, every fracture is having two components. One is mechanical component, other is biological component. By fixing it or doing bone grafting, you are taking care of your biological component. But because of mechanical component, that if it remains same, the chances of failure will be high. You are right, somebody treated first fixation of the fracture, and after that they used to do the replacement of the knee joint in second stage. But if you don't take care of the mechanical alignment, whatever the fracture, if your femur is in is varus and you fix it in varus, then the chances of failure is high. Similarly in tibia and whatever the bone. So
Exactly,
mechanical correction should be done also.
So, besides fixing the fracture, can we not correct the mechanical deviation and tackle the osteoarthritis also? Can we not do a
Yes.
replacement with a
So
long stem?
both can be tackled simultaneously.
Because we have a severe arthritis also.
Particularly in left. Particularly in left.
Patient will still have pain.
Yeah.
Yes.
My
So,
question.
Dr. Gupta, what you have planned?
Yeah, so I have planned for the knee replacement with augmentation both the sides. With this fracture, she has for more than 4 months. She has previous X-ray also that was showing the fracture, and this X-ray she has for last 4 months. So I plan for something. This incidence already you people has discussed, so I'll escape. She has. So I have planned for something like this. This is for the left side, and this was for the right side. This side I plated also, and that use the bone that I resected as a bone graft there, because that was 4 months old. And this side I just used this augmentation for the tibia, because there was impending stress fracture there also. And this was done on the 9th May 2019. And at the same time, vitamin D and everything, she was started. Because we all know vitamin D correction sometimes might take more than 6 months to get corrected. So waiting for till that period, and considering the walking pattern of this patient, I think this is not very wise to wait for get vitamin D and other part get corrected. And this is the X-ray after almost 1 month. You can see that this fracture is getting healing on the left side. Right side, this part is getting better. This part is getting better. And this is the lateral view, you can see. And this is after 1 month when she came. That time was the X-ray, and this is immediate after 1 month after this surgery. His pattern has improved, though because of very weak the quadriceps and the gluteus. Still there is little bit of blood that she got improved on telephonic, because she was from very rural area, and the money arrangement was very big for her. We called 1 week earlier because of this osteoporosis and arthritis World Day, but she not able to make it because of all these puja and thing. So this was the walking pattern after.
One point is here, Dr. Gupta. Yeah. Did you use PTH in this case?
Parathyroid, no, I have not used parathyroid hormone, because we think this, if we'll correct the mechanical axis and we'll correct the knee joint with the knee replacement, so mostly part will be taken care by the calcium, vitamin D, and her walking pattern, because she is very less walker for very long time. She used to refuse.
I do agree, but there is a point here that her cortices were very thin. So for stability and for the integrity of the bone.
I agree with Manoj sir, because after fixation we should start teriparatide.
Yes.
So may I disagree?
This is my view.
Because teriparatide is not for the fracture. The ideal indication for the teriparatide is if patient is having one vertebral fracture with severe osteoporosis. The patient spine was fine, though little bit, but there was osteoporosis.
Not just for spine, we think it's for bone density, increasing bone density in any osteoporotic bone.
Definitely. So that you can get with other method. I usually prefer this parathyroid hormone for those who having vertebral fracture with severe osteoporosis, and those particularly having less vitamin D, low vitamin D, I used to avoid this parathyroid hormone for that type of patient.
Okay.
One contraindication for not using parathyroid hormone in this case was low vitamin D.
Yeah.
Right.
Okay.
So may I go to the next case?
Yes.
Yes.
So this is, all these are for theory pattern, how long you should use your tibial stem and how much having cemented and uncemented part is problem. This was the second patient, similar, same with, you can see, sir, present in our scenario and our culture, they used to wait for so long period so that this arthritis caused the fracture of the bone. It's not the traumatic fracture of the bone. You can see the proximal tibia is on the medial side, almost gone on the both the sides, and the patient is still waiting for all these magic by the quack and other things. So this is the, you can see the quality, and also at the same time the thing which we face day by day, every day. Was the X-ray. And what the problem you can face, Dr. Rohit?
Yes, sir. Regarding what, sir? Problems regarding?
Treatment part.
So there is the X-ray shows severe osteopenia, probably osteoporosis. I'm assuming this is osteoporosis.
Yeah.
And the collapse of the medial aspect of both the joint line is there. So first of all, because of the collapse, the bone quality, when we replace this patient, probably we are going to have medial collapse later on if we do not augment it by some way or the other.
Perfect.
And yes, this quality of bone has to be corrected. Otherwise, ultimately, this is going to lead to failure of the implant.
Yeah, good. So do you think only augmentation will work? Here you can see the loss of the medial side of the tibia. Do you want to do something here also?
So
Or here?
yes, sir. I'm not very sure what we call them because I'm not into replacements yet. But they have this steps, different augments that technically form the base of the proximal tibia. And along with bone graft, yes, bone graft is ultimately required because the implant is going to sit on the bone graft.
Yes, you're right. This will need bone grafting.
Yeah. So there is no confusion regarding TKR in this case, Gyan?
Yes, sir. There is no confusion, sir. We can go for a 3D reconstruction also.
Okay, perfect.
Right,
So we plan for the same total
Yes,
knee
sir.
replacement, and at the time of knee replacement, you can see on the medial side this huge defect is there. You can see this is the level on, and this just the medial to the central part. Everything was lost. Only soft tissue was there. You can see here. So this very big, huge area, almost around 40% of the medial condyle of the tibia was almost lost. So here are the options, as Dr. Rohit pointed out. You can increase the bone dissection. You can, this away from the defect, you can shift more toward the lateral side. You can use bone cement, that is usually for 2 to 5 millimeter. You can use bone graft. As Dr. Rohit also said, bone graft, everybody was agree with that. So in our scenario, we mostly use bone graft, but in the Western population, they mostly get treated with the metal wedge. And of course, the augmented tibial component should be there. So I decided for the bone graft in this case. And you can see the final after resecting complete, this much was the defect. And we use the bone cut there. We check for this, the size of this bone cut, the bone graft. And that was get fixed with the 3 screw. You can see the size of this bone graft, which we have taken from the tibial cut and fixed with the 3 screw. That this should be away from this central line. Otherwise, this is going to hamper with the tibial sleeve. And this is the after fixation use of the 3 screw and the big, very thick the tibial sleeve with this TKR. You can see there.
Was there any delay in mobilizing patient or weight bearing because of the screws and bone graft?
No, the mostly were taken care by this tibial stem.
Long stem,
So
yeah,
there is
perfect.
no problem with that. In fact, you should increase the early weight bearing so that your bone will get consolidated with the time.
Perfect.
And this was for the opposite side. That much of the bone defect was managed with the cement. That was around 5 millimeter. And also the tibial sleeve was used. So this is for the other side. Thank you. Any question, please?
Right.
Thank you.
Thank you, sir. Sir, two questions, sir, I want to ask. First question, sir, is it necessary like to put both the side stem? Like this is, I have seen few TKR, I have assisted few, sir. Like both the sides of stem should be same.
See, if you see the X-ray of this patient, so indication for the tibial stem is if your bone is very severe osteoporosis, even though it's not in the very severe varus. So if you have very severe varus with severe osteoporosis with the defect on the medial side, so ideally these three are stress fracture. These four indication for the tibial augmentation while doing your TKR. So these four ideal for it. Or fifth extended indication if your patient is very obese, very wetted, more than 100 kg type of patient. So all these five indication, we have seen the three indication, the defect on the medial side, stress fracture, very severe varus, and fourth is severe osteoporosis also. You can see all these bone are very poor quality, though its side it looks good, but this side the bone is very poor.
Very poor. Sir, agreed, sir. Sir, I just wanted to know that both the sides, once we put on the long stem on the right side, we have to put same size stem on the left side also, right, sir? Or even if the biochemical markers are not up to date, still we can move ahead for surgery.
See, if your D and other thing get corrected, even it take more than 6 months or something like that.
The
So
risk benefit
the part is low, and at the same time she or he has osteoporosis, so that part should be get corrected first, because many a time because of osteoporosis your tibial.
So that one should get a take-home message that if you have arthritis with deformity, you must not take steroids for a very long time. It will further add to your deformity and may cause fractures. And if you have a fracture,
Management like anti-resorptive drugs or anabolic drugs. What is your post-operative management?
Most of the times, sir, I start with all the osteoporosis. First, I try to start the hip and back also, because mostly my osteoporosis patient is having weakness with the back and the muscle. The gluteus muscle is very important, that control your trunk as well as the both lower limb also. So usually my physiotherapists work on that also. So that takes some part of pain also. From the medical point of management, I start with the calcium, and those who are having deficit of the vitamin D, I usually start with the vitamin and the high rich protein diet. That is very important. We have seen in the presentation of Dr. Rohit, he showed the bone is having this protein matrix on which the calcium get deposited. So that part also get corrected, and then bisphosphonate usually I start.
What is your experience about zoledronic acid and peritherapide or denosumab? Do you prescribe these drugs?
I use all three drugs. The zoledronic acid is definitely very good drug that has to be used once a year, and that is really very good drug that takes care of your osteoporosis. And second part is the teriparatide. My indication is those who are having vertebral fracture with osteoporosis, and this drug is having tremendous effect on that type of patient. If patient comes to you osteoporotic fracture of the spine with osteoporosis, believe me, give patient. But believe me, if you give only 2 to 3 months of drug, then you don't require any type of analgesic for that. At the same time, you should start the back exercises also. That should be at least 2 hours in 24 hours, that type of patient. One extended indication is that we have discussed that in fracture, if we should start. Some type of patient, those who are having multiple fracture throughout the body, that is the polytrauma patient, I used to give this therapy. I use denosumab hardly for 4-5%, those who are having reimbursable, the money get reimbursed. And as we can see the literature, this drug is having very good effect. So maybe in future, this will be used very frequently and we'll see the effect of that drug. Because many a time what literature says, what this company says, will not come with the time after 5 years, 6 years, 10 years, like calcitonin. We have seen people have used like anything, but recent literature says the calcitonin has nothing to do with the osteoporosis.
Right, right.
And
Very
people
right.
have used, I also have used like anything. Everybody of osteoporosis used to prescribe this nasal puff. Very easy to take, except nasal crusting in some patients. But recent literature says this drug has nothing to do with osteoporosis.
Right.
So I will wait for denosumab. But teriparatide, I have very good experience with patient with vertebral fracture with severe osteoporosis.
I would like to add an extended use of teriparatide in my Elizaro cases where I have to do around 5 to 7 inches of bone transport and the bones are very sclerotic. And then when I add teriparatide, the bone regeneration is very good. That's another use, sir.
Right. Right.
So maybe Dr. Hoda, I have used this teriparatide for many of my distracted patients. But
Exactly.
believe me, I don't find any significant difference in between those I have used and in those I have not used. So I have stopped using this teriparatide for those. Bisphosphonate is having some effect.
Yeah.
You use bisphosphonate for this Elizaro distraction.
Okay.
Those who having degenerated bone having some effect on that.
And I've seen in the patient with poor regenerate after adding teriparatide, the regenerate was very good in few cases.
So for some patients with delayed healing, we have seen that teriparatide actually helps. Though it is not literature proven yet.
Exactly.
There is no support teriparatide for fracture fixation, but I don't know, it works.
Yeah.
But in few patients, it doesn't work also. So
Exactly.
Data has to come.
Depends. Yeah.
The use of teriparatide, one experience what I had when I was at Ganga Hospital, Coimbatore, Ajay Sethi sir, he used to say if you want to use teriparatide, you should use it for 24 months.
Yeah,
I will write an injection to you. I will only write that injection if you use it for 24 months. Otherwise, I will not write it. So that's what he used to say. And without lying, recently I have done also Elizaro 5 centimeter. Dr. Huda is aware of it. And I was also using teriparatide in that case. And case is doing really very good. But fracture indications, I've seen in Delhi also. When I was working, lots of people after bone grafting and all, teriparatide was given. And results were good. But nowhere in the literature it's mentioned nowhere. Anyway, we have different experience.
We have clinical different experience. Yeah.
And second, very bad experience. One thing what I saw, one thing how disasters can happen about denosumab. That time I was there at Indian Spinal Injury Center, and one of the fellow who had just completed his fellowship after 2 years, he gave denosumab to his own nanny. And suddenly she went into hypocalcemia. Hypocalcemia means calcium into 3. And he came crying to Chhabra sir and he says, sir, please save me. Everybody at my home will kill me now. And Chhabra sir was consoling him like, don't worry, beta, nothing will happen. You just administer some calcium. So denosumab, I have not used it. I have seen 1 or 2 cases, but I don't know. Maybe Saraf sir has some experience.
Saraf sir, what is your experience with teriparatide?
It is not available in our market, and I have never prescribed that drug.
Right,
theoretically, I will prescribe.
So
But
with this,
I am a regular prescriber of teriparatide. So many companies depend on me for sales.
Yeah.
So, Dr. Gyan, you rightly pointed out about the calcium level. Even before starting teriparatide, you should have documented the calcium level as well as the vitamin D.
Vitamin D, that is very important. That's very
Should be
important.
also documented before starting the teriparatide. And
Yes, sir.
teriparatide give the maximum benefit at the period of minimum 16 months.
That is the minimum period.
Maximum benefit. There is a difference. You can see this is the maximum benefit, like 100%. But your patient may be benefit with 25% also of the effect of this teriparatide. So you can give for 3 months also. But the maximum 100% benefit patient will have at the end of 16 months. So minimum 16 to 24.
Manoj sir, would you like to add something? Your experience with teriparatide?
Yes. Dr. Gupta has said that it is going to benefit if we prescribe this teriparatide for 16 to 24 months. So who is going to benefit it? So please clear whether the patient is going to be benefited or the pharmaceutical company.
Will we try, sir, our best to give the provide the patient directly with maximum discount, sir?
It
That
is
I
very
usually
costly.
do. Yeah,
see,
because it is very costly.
Very
so
costly,
yeah,
and prescribing it for 24 months is not
exactly,
a
sir.
do. Yes. So
Sir,
we will have to look for some medicines which will be cheaper, more affordable, and will have almost same effect like teriparatide. So I shall request.
I will add one thing. I will add one thing. I will add one
before
thing.
that,
Cost of surgery, cost of osteoporotic fracture surgery is much more than the teriparatide. Number one. So there should be certain regime for prescribing in high risk patient, in post fracture cases. There should be some definite regime and guidelines. And I hope honorable faculty will advise for that and give the guidelines. What should be the proper guidelines in high risk cases and post operative cases? What should be proper guidelines?
I have another thought about calcitonin nasal spray. Calcitonin nasal spray in vertebral fractures, it helps. I mean, at least it decreases the pain over a period of 1 or 2 months. That it works, but I don't know.
Yeah, you are right. So that is analgesic effect of that drug.
Yeah.
Because of the osteoporosis.
Yes, sir. Yes.
It's analgesic effect only. You are right.
Madhusudan sir, would you like to add something, sir?
Sir, I just like to point out, sir, there is no written literature ki post-operative, sir, when we read literature, whatever publications are there are not much things written about ki if we administer teriparatide, fracture healing would be fast. But when we use it, we see it's fast. And at our setup, so it's one thing we can do is we can make our own guidelines working together with few surgeries and the outcomes we can calculate. I've not seen such a paper published yet.
Yeah, so maybe Gyan, you just treat 20% of your fracture and give teriparatide to 10 and don't give to another 10. And then comes with the conclusion after 6 months. And please post your opinion in BOA group.
What I did, I prescribed teriparatide to one patient and asked to take fish, lot of fish. Results will go to the same almost. So cod liver directly helps here. So I request now to Gyan to share a slide about treatment of osteoporosis.
Sure.
Before next session.
Yes. Honorable President-elect, respected Secretary, sir, other members of faculty, Dr. Samsul sir, and I'll start with it. Treating osteoporosis involves treating and preventing fractures and usually medicines to strengthen the bone. Diagnosis of osteoporosis is based on result of your bone density and other investigations. Treatment. One second. Yes. Decision about what treatment you need is based on a number of other factors, including your age, sex, risk of breaking a bone, and previous injury history. Medications for osteoporosis: bisphosphonates, selective estrogen receptor modulators, parathyroid hormone, monoclonal antibody medications, calcium, and vitamin D. Calcium is the main mineral found in bone. Balanced diet is important for maintaining healthy bone for healthy adults. Recommended amount of calcium is around 700 milligram of calcium a day, which most of the people should be able to get from a varied diet that contains good source of calcium and or supplements. However, if you have osteoporosis, you may need more calcium. This picture shows some of the food items which contains more calcium. Vitamin D. During the autumn and winter, vitamin D helps the body to absorb calcium. All adults should have 10 microgram of vitamin D a day. For about April to end of September, most of the people should be able to get all vitamin D they need from sunlight and sunlight on their screen. Eggs, raw milk, mushroom, tuna, sardines, salmon, mackerel, and these are the few food items which contains good amount of vitamin D. Since it's difficult to get enough vitamin D from food alone, everyone, which includes pregnant lady and breastfeeding women especially, should consider taking daily supplementation containing 10 micrograms of vitamin D. Bisphosphonates. We have non-nitrogenous bisphosphonate and nitrogenous bisphosphonates. In osteoporosis, we mainly use nitrogenous bisphosphonates. It is anti-reabsorptive agents bind to hydroxyapatite crystals in bone directly or indirectly inhibits osteoclast, inhibit bone mineralization, pharmacologically active on while on exposed bone surface, remain bound in bone matrix for years. This is mechanism of action, bone. There is osteoclastic activity. It works here and stop this osteoclastic activity. Finally, osteoblasts are building new bone and new bone is formed. FDA approved bisphosphonates for osteoporosis. Alendronate, 70 milligram weekly can be given or 10 milligram daily can be given. It is given by oral route, abdominal pain, skeletal pain, constipation, diarrhea, various GI symptoms. Other side effects. Ibandronate, 2.5 milligram daily or 150 milligram monthly, oral or IV route can be given. Various GI irritation, headache occurs. Other side effects. Risitronate, it is given 5 milligram daily or 35 milligram weekly, 75 milligram per day for 2 days each month or 150 milligram monthly. This is given by oral route. Back pain, arthralgia, abdominal pain, dyspepsia can happen. Solidonic acid treatment is 5 milligram once yearly given by IV route. The infusion time should be more than equal to 15 minutes. It shouldn't be given in less than 15 minutes. Flu-like reaction usually with first dose pyrexia, myalgia, headache, arthralgia, pain in extremities happens. Bisphosphonates are given as tablets or injections. Always take bisphosphonate on an empty stomach with a full glass of water. Stand or sit upright for 30 minutes after taking it. You will also need to wait between 30 minutes to 2 hours before eating food or drinking any other fluid. Bisphosphonates take 6 to 12 months to work. May need to take them for 5 years or longer to treat osteoporosis. Main adverse effects are irritation of the food pipe, swallowing problems, stomach pain. Osteonecrosis of the jaw is a rare side effect which is uncommonly seen. Selective estrogen receptor modulators, SERMs. SERMs helps to maintain bone density, reduces the risk of fracture, particularly of the spine. Raloxifene is the only type of SERM available for treating osteoporosis. It is taken as a daily tablet. Other SERMs are clomiphene, tamoxifen, tomifene, and omolixifene. Adverse effects are hot flushes, leg cramps, potential increased risk of blood clots. Parathyroid hormone. Parathyroid hormone are produced naturally in the body, regulates the amount of calcium in bone. Parathyroid hormone treatments such as teriparatide are used to stimulate cells that create new bone. They are given by subcutaneous injectable route in a dose of 20 microgram per day up to 2 years. While other medicines can only slow down the rate of bone thinning, parathyroid hormone can increase bone density. Used in a small number of people whose bone density is very low and when other treatments are not working. Adverse effect of parathyroid are nausea and vomiting. Hormone replacement therapy. Hormone replacement therapy is sometimes taken by women who are going through menopause. It can help to control symptoms. HRT has also shown to keep bones strong, reduce the risk of fracture during treatment. However, HRT is not specifically recommended for treating osteoporosis as rarely used for this purpose. It has severe adverse effects which can develop certain conditions like breast cancer, endometrial cancer, ovarian cancer, stroke, venous thromboembolism. More than it lowers the risk of osteoporosis. Monoclonal antibody, recently launched, not very old, Prolia, in the name of Prolia, and the composition is denosumab, 60 milligram per ml. Denosumab inhibits the formation and activity of osteoclasts by blocking the receptor activator of nuclear factor kappa B ligand. Dose of 60 milligram given subcutaneously every 6 months for 3 years. It significantly increases BMD in postmenopausal women compared with weekly dosing of alendronate. Denosumab decreases hip, vertebral, and non-vertebral fracture compared with lower doses of calcium and vitamin D. Appears to be a reasonable alternative for persons whose condition does not improve with bisphosphonates. Renal insufficiency is a listed caution, but denosumab appears to be safe for patients with chronic kidney disease stage 1 to 3. Before starting denosumab, you should have a dental examination. You should continue to take good care of your teeth. See your dentist regularly while you are on them. Make sure your dentist knows you are taking these medications. You should check your level of calcium, vitamin D, and alkaline phosphatase before you start denosumab. Adverse effects. Complication of denosumab: break or crack in the middle of the thigh bone. Secondly, delayed healing of the jawbone, that means osteonecrosis of the jaw. If we go by numbers in osteoporosis, 30 is the age when you reach the peak of your bone mass. 50 is the age when bone loss increases, especially in women. 10 million number of Americans who live with osteoporosis. 45 million is the number of Americans who have low bone mass. $19 billion is the annual cost of osteoporosis related fractures. The best 3 ways to treat osteoporosis is get adequate amount of calcium, get adequate amount of vitamin D, exercise regularly. Prevention and treatment of osteoporosis: take diet, take dairy products, take a good sleep, calcium and vitamin D supplementation, limit your coffee, stop smoking, drink less alcohol. That will always be very helpful. Thank you. Over to Samsung.
You, Dr. Gyan, please unshare your screen. Any questions, sir?
I have to get some information from Gyan.
Yes, sir.
Is there any role of estrogen patches in osteoporosis? And is it available in our country? Estrogen patches, because raloxifene is not anti-osteoporotic drug. It simply relieves some complaints of menopause. So there is no action of raloxifene in osteoporosis. Estrogen patches works. So far as I know, it is available in UK, USA. Is it available in our country or any town?
No, sir. I haven't seen one. I have not seen one till. About raloxifene, sir, the information what was it decreases like whatever postmenopausal effects for postmenopausal osteoporosis it is used, sir. But it should be, as I have said in my slide, it should be used cautiously because sometimes risk benefit checking out the risk benefit ratio, and once we are giving it to patients, we should be very cautious.
My second question is how you avoid acute phase reaction after prescribing zoledronic acid. Acute phase reaction, like fever is most common complaint.
Yes, sir.
So how you avoid? How you avoid that? Is there any tips?
No, sir. What I used to do when what I am doing right now also, sir. When I'm using it, sir, I'll take your opinion also that we are learning. I put it very slow, as slow as I can.
That is one thing, but fever cannot be avoided.
And sir, secondly, sir, we can give a dose of paracetamol 500 milligram before that. That's what, sir.
I have one information to give you all.
Sure.
To avoid acute phase reaction in zoledronic acid, you first hydrate the patient with RL 1 pint, paracetamol 1 gram, and efcorlin 100 milligram. In most of the cases, 50% complaints of fever, in 50% of the patients, the complaint of fever diminishes, right? And even after prescribing this, any patient complains about this, you prescribe deflazacort for 3 days. So there will be no fever or no complaint, right?
Thank you so much, sir.
My question, Dr. Gyan. In young patients with having hysterectomy with removal of ovary, we give HRT. So what should be the duration of HRT for the young lady?
Sir, usually what we do is we give it for 3 months, and we after giving for 3 months, we should keep reviewing.
Okay, sir. Okay. Any other more added knowledge on HRT? Because this is very common in Bihar, because young ladies get hysterectomy with ovary also. Manoj sir or Sarab sir would like to add something on HRT more.
No, I have no experience of prescribing HRT because I know that this is not anti-osteoporotic drug. There is no roll-up in osteoporosis of raloxifene. But I have listened that the estrogen patches have got some rule. If you prescribe estrogen patches, this can be patient can be well treated. In female can be well treated. Number one. Number two, combination of drugs has got role. Like you prescribe anti-resorptive drug as well as anabolic drug. This has got some role. In first phase of post-operative, like after 4-5 days of operation, I prescribe zoledronic acid, and after that, I prescribe teriparatide. This has got marvelous results. In union of fracture, this has got marvelous.
Manu sir, a very important part that in osteoporosis, diet has a very important role. Would you like to emphasize on that, sir?
Of course.
For common public, sir, because this is live on Facebook also, sir.
So diet has a very major role in combating this osteoporosis. Diet supplemented with vitamin D is required, and diet rich in calcium should be taken. Dr. Gan has said about the diet also. So he has shown a slide in which calcium-rich foods were shown. Can you share the slide, Dr. Gan?
Yes, sir. Yes, sir. Of course, sir. I'll share.
Please emphasize on the foods. That is very important part.
Dr. Shamsul.
Yes, sir.
Sir, I like to tell something. Yes. Dr. Mohipal has already told poor absorption, poor intake, cause of the osteoporosis, poor intake, poor absorption, and I'm audible.
Yes, sir. Yes, sir. Please.
Poor absorption and malnutrition. Osteoporosis definition is the decrease of bone mass. Okay.
Yes, sir.
Decrease of the bone density. What the content in the bone? That is the protein, that is the calcium, that is the minerals. Mainly these are the decreased. So our aim is to first give the protein-rich diet. Okay.
Yes, sir.
Second is the minerals, vitamins. Minerals means calcium and other supporting minerals. And third is vitamin D. For vitamin D, sun rays is one of the important factors. So sun bath is one of the important. Okay.
Yes, sir.
So diet should be of the protein-rich, calcium-rich, mineral-rich, and sun bath. These are the very important factors to prevent the osteoporosis. It is my opinion.
Madhusudan sir, okay. I'd like to extend details about the exercise, role of exercise in osteoporotic bones, sir.
Exercise also, you have asked about the diet, but exercise is also one of the important factors.
Yes, sir. So what exercises should elderly should go for an osteoporotic bone? What is exercise recommended for the knees, for the hips and the spines?
What exercise?
Yes, sir. Basic knowledge of the exercise and the yoga, sir, for the osteoporosis, sir, for general public, sir.
And that is very important. Exercise and yoga, these are the supporting factors, very important. Okay.
Can I speak on that?
Please, please.
Yes.
So the exercise, see, as far as the bone strengthening is concerned, the most important aspect is increasing the weight-bearing exercises.
Yeah.
So the more pressure the bones tend to have, the better the bone quality tends to increase. So weight-bearing exercises, weightlifting exercises definitely help. Muscles strengthening is important because then it it stimulates the bones at the joints, near the joints, so as to increase the mineralization at that point. For the back, I think core strengthening exercises for the back, that helps a lot, sir. I think that's it from my end, sir.
Yeah. Is there any role of braces in the osteoporotic spine or knee?
So braces help until the time that we can correct the osteoporosis. So once the osteoporosis is corrected, it's not an issue. But vertebral fractures and mainly vertebral fractures are very important. So I had attended this webinar where they talked about preventing falls, preventing injuries in old aged persons by changing things at home, and that helps in preventing. Braces was one of the aspects. This is that apply braces, and that helps in preventing injuries to the vertebrae as well as the hips.
Actually, sir, what you are saying is the mechanical load that comes down. Using the brace, the mechanical load comes down. That's what they are saying. And one thing I like to add about the food, what we were talking about is spinach, kale, okra, collard, soya beans, white beans. So that would be really help in like calcium and vitamin D supplementation. For any of the osteoporosis, sometimes in osteoarthritis also there is a brace exactly that shifts the weight. In early osteoarthritis, like medial condyle osteoarthritis, there is a brace which is very costly. I used to see in Delhi, in Charakpalika Hospital, they used to use for till up grade 2 osteoarthritis. That is very helpful. In the same way, what you are saying for the mechanical access to change, they use that. Am I clear? No.
Right. Yeah, you're clear. Saraf sir, any role of osteoporotic spine like kyphoplasty, something, sir?
Actually, this was subject is a basic. This subject was for a vision.
Right, sir. Right, sir. Right.
He is treating a spine case.
Just 2 lines, sir.
But after operation, usually prescribe thoracolumbar brace in most of the cases for 3 to 6 weeks.
S brace.
And do you use teriparatide in spinal fracture cases and post-operative period?
In most of the cases.
Yes.
In most of the cases, they are purchasing, no problem.
How many? How long?
It should be ideally prescribed for 2 years, but we don't say that you use for 2 years. First we prescribe for 3 months, later only again we prescribe for 3 months, because problem is money with our patient.
Yes.
Economy is problem.
Since
patient can maximum take for 3 to 6 months only.
I have used it for 3 months in spinal fractures and found that this has some effect. Yes. The patients are benefited, and they come themselves that please, may I continue for a few months more?
Yes,
they themselves say. So this is a good sign that teriparatide is working. Except cost. If the cost factor is not there,
Sir, now even the cost has come down a bit. Intas has brought it down.
We usually request the pharmaceutical companies to deliver the patient directly with a very discounted rate, sir. That we usually do, sir.
So, but I have a point here. What I want to say is that we do not consider denosumab yet because of its availability, but the cost of denosumab is not that much. For a 6-month therapy, for denosumab, sir, we talk about teriparatide, though it's very effective, but the difficulty in taking daily as an injection is sometimes troubling for the patient. Denosumab, on the other hand, has to be taken once in 6 months. The cost is, at the market value, it is about 25,000, but you can get it at around 15,000 if you contact the company directly. And every 6 months, 15,000 is probably not that,
I agree with you. The point is, you prescribe teriparatide, you train the patient how to take it, but still they will call some person for injection, and then this injection cost, the person who is coming will charge, and the cost will increase automatically.
Yes, sir.
So prescribing teriparatide is not so simple as we see in our scenario.
So, Saraf sir, I have seen an article that in osteoporotic wedging, not fracture, teriparatide also helps in alleviating the pain.
Yeah,
How's
yeah,
the
it's
experience,
true. It's true.
sir? Sir.
Actually, it increases the level of it increases the bone marrow
Exactly,
density.
sir.
Teriparatide, along with anti-resorptive drugs, it should be prescribed. We first prescribed zoledronic acid. After 4-5 days of the operation, then we prescribed teriparatide for 16 months. And most of the patient perceives it, no problem.
Thank you, sir. With this, can we, sir, end or shall we extend, sir?
Sir, it's okay, sir. It's made.
Manoj, sir, I will request you to say 2 words about we are having this bid for Icon Patna. We are already live. Please say 2 words, Manoj sir and Madhusudan sir, for the voting for Patna.
Everybody knows nowadays that Patna has bid for IOACON 2023. We have much better facilities here. We have very good, rather international standard of our convention hall. We have parking places, and we are humble person, Atithi Devo, with a vision of Atithi Devo Bhava. Whenever we talk of this conferences, what comes into our mind? The good academics, and the academics everywhere will be same. The same faculty will go either this way or that way, either here or there. But the places to visit are quite different at different places, and we are very much rich in this aspect. We have Buddha circuit here. We have Guru Gobind Singh Ji birthplace. We have Jain temple. We have footprints of Lord Vishnu at Vishnupat temple. Only one in whole world. Nowhere we will find the Vishnupat temple, just like in Bodh Gaya. And Bodh Gaya is only 1.5 hour journey from Patna. If you wish to visit Mohpalji at Darjeeling, it is only 90 minutes. Yes, Mohpalji is here to welcome you at Darjeeling.
As always, sir.
Yes. Similarly, we have adventures like Tiger Reserve. We have so many places to visit. We have ropeways. We have hot springs, coconut waterfalls, and so many places to visit. And we offer everything free. All the visits will be free from our side. We will arrange it. We will be there with folding hands to welcome. We are humble person. We will offer litti chokha and other foods. So please come to us. Please vote for Patna and help us to show our gesture. Thank you.
Thank you, sir. Now I request our secretary, Madhusudan sir, to conclude and say a few words about Icon Patna bidding, sir. Sir, please unmute yourself, sir. Please unmute, sir.
Respected all the members of the IO, we are contesting, Bihar, Patna is contesting for the IOCON 2023. So I request all of you to please vote for the Patna. In Patna, everybody know conventional center, Bapu Bhavan, Gyan Bhavan, is a very big center. I think it is one of the best center in our country. And all the hotels, it is near the Gandhi Maidan, and all the hotels around this conventional center. Airport is around the 4 kilometers. Railway station is around the 2 kilometers from the conventional center. There are so many religious places in Bihar. Everybody know Rajgir, Bodh Gaya, Vaishali, Guru Gobind Singh Sahab, and a part of these tourist place, these religious place, our academic part is very strong, and it will be guided. It will be done by Dr. John Mukhopadhyay. Everybody knows Dr. John Mukhopadhyay. So our academic, our hospitality, our conventional center, these all are one of the best possible. So I request all the IU members, please vote IUCON 2023 for Patna. You all are my Atithi and Atithi Devo Bhava. Please vote for Patna. I request again and again, please vote for Patna. Thank you.
Thank you, sir. Vote of thanks, sir.
Shamsul, sir,
First,
can I say something?
I like
Please,
one
please, please.
question. Dr.
Sir, Dr. Gyan wants to say something before vote of thanks, sir.
Dr. Samsul.
Yes, sir.
Dr. Samsul.
Yes, sir.
I want to one question from Rohit Mahipal.
Yes, sir.
Dr. Rohit Mahipal. One
Yes.
thing, this program is World Osteoporosis Day. In this program, the aim is to prevention, diagnosis, and cure of the disease. This is the we all will discuss it. One thing I like to know: what is the in osteoporosis? What is the first symptom? The patient come in our clinic having the fracture, like the college fracture, like the fracture knee femur, like the back spine fracture, having pain. But she or he has osteoporosis. What symptoms she told to their family members or she or he felt? First symptom.
So usually the most common symptoms that we find is that the patient had a fall, a trivial fall, maybe just an outstretched hand, and then she had a fracture, and then incidentally osteoporosis detected. Others from that, as symptom is concerned, low back pain is quite common, concerned with vertebral fractures. That is a very common presentation, and old patients sometimes present with stooping. They decrease in height, sir.
Decrease in height, yeah.
Yes.
In spinal, mainly in the spinal problem.
Yes, sir.
लेकिन वो अपने जैसे अपने घर वाले को चाहे क्या बताएगा, चाहे अपने क्या फील करेगा, व्हाट दे फील, ये वो क्या हो रहा है, ऐसा कुछ होता है क्या फर्स्ट सिम्टम से? नहीं.
पता नहीं सर.
Gyan, you want to say something?
Actually,
Dr. Gyan, please unmute.
Dr. Gyan. Dr. Gyan.
Yes, sir. Yes, sir. Yes, sir.
You want to tell something?
Yes, sir. I just wanted to say regarding IFON 2023, as we all are live and all those our friends who will see this video, I'm telling you, you will have, as Manoj Chaudhary sir said, you will have academics everywhere. Come for our hospitality in Patna. Bihar has many cultures, many sites and many cultures. We will provide right of Chuda of Bhagalpur to Mithila ka Makhan, right? Aapka Champaran ka meat, every food cuisine. What other places might be famous, we'll provide you much better than that, much different than that. All cultures of Bihar will be shown at the site where we have our food area. Mithilanchal will be a corner, Champaran will be a corner, Bhagalpur will be a corner. Just come over. Once for all, you should come and see. Till the time you don't come, you won't see it. With folded hands, but please come to Patna.
Saraf sir, would you like to add something for IOCON?
I think he left. Sir left.
No. I'm still present.
Sir there. Okay, sir, please.
Please unmute, sir.
Unmute, sir. Sir,
Patna is historic. Unmute. Right.
No, done, sir. Sir, please. Yes. Again, sir. Sir, please. Now, yeah.
Now I'm audible. Patna is a historical place. There are so many places to be seen in Bihar near to Patna. And history is lying in this all places. Those members who have not come to see, those persons who know the history of Patna and Patliputra, they should come here. And our hospitality is most popular. Bihar is famous for hospitality. So I invite each and every members of IOA to come and see the Patna and enjoy the hospitality of our Biharis. Right? Thank you.
Thank you, sir. Thank you, sir. We request all the members of IOA with folded hands. This is a place of culture. This is a place of knowledge. Nalanda, Guru Gobind Singh, Valmiki, Please vote for us. Give us a chance, and we would like our hospitality. Thank you, sir. With this, shall we end the webinar, sir? Live, sir. Manoj, sir. Please.
Samsul, Dr. Samsul.
Yeah, Manoj, sir. Yeah.
Vote of thanks.
Yeah, please,
respected President, sir, respected President-elect, sir, and all the seniors, dear friends, and all the speakers like the Dr. Arvind Prasad, Dr. Rohit Mahipal, Dr. Gyan Ranjan, and Samsul also. Today program webinar is really very nice, very beautiful, and I give thanks to all of you. We learn a lot of knowledge about the osteoporosis on this World Osteoporosis Day. So I give you thanks again and again. Thank you, everyone. Oh.
Thank you, sir.
Thank you, Manoj, sir. Thank you, Manoj, sir. Thanks, everybody, sir. With this, I'd like to end the live stream, sir. Thanks again.